In the third section of our lecture, now we will talk about the clinical features of pre-eclampsia. In this, we will talk about how pre-eclampsia present, how we can examine the patient with pre-eclampsia, what are the different investigations that can be performed, and how we can manage the pre-eclampsia. So patient with pre-eclampsia, we know now what pre-eclampsia is, which is the increased blood pressure, increased protein in the urine, especially after the 20th week of gestation, and it gets normal after 6 weeks postpartum. So presentations, how pre-eclampsia will present, patient will have a stomach pain, feeling nauseous or throwing up, swelling in hands and feet. Swelling is present when the pregnant women, they wakes up early morning. Usually they have profound swelling of the face. That's the indication that the hypertension is present or there is preeclampsia setting up. So very, very important that they should notice if there is any abnormal swelling on the face or in the legs or in the feet. Headaches are common because of high blood pressure. Seeing spots, usually they see spots in front of the eyes, and gaining more than 5 pounds in a week is also present. Loss of weight gain, swelling, if the weight gain is more than the recommended weight gain of pregnancy, that should be an indication that there is something wrong. So even the pregnant women, they can notice excessive weight change and they should go to the obstetrician and then have tests performed. Clinical examination, usually obstetric examination, is hypertension is usually the first sign. Rapidly progressive edema of face and hands, epigastric tenderness. So if they think that their rings are not fitting them and their hands are all swollen, if they see swelling on the face, or there is epigastric tenderness, that's the first indication usually that there might be pre-eclampsia. Neurological examination usually show hyperreflexia. Reflexes get exaggerated, like elbow jerk or elbow reflex, knee reflex, all these patellar reflex, they become exaggerated, and there is clonus present, which is the exaggerated movement that is present. Clonus is also on neurological examination. Testing for proteinuria, dipstick urinalysis is very basic test that should be performed on each antenatal visit. The urine is collected and then urine dipstick is inserted into the urine. That gives the rough idea if protein is elevated in the urine, and then they need to do further testing. So basic testing for proteinuria, we have dipstick urinalysis. Instant result is available, but it's not quantitatively very accurate test, but again it gives the initial indication of setting up preeclampsia or presence of protein in the urine. Trace is seldom significant, it's always present, trace amount. 1+ possible significant proteinuria, more than 2+ or equal to 2+ probable significant proteinuria warrants quantifying. So if it's traces, everybody usually when we do dipstick test, usually some traces are present, but 2+ is significant, should be done with quantity, should be done with the further testing. Protein creatinine ratio, a fast within 1 hour results semi-quantitative. more than 30 milligram per mole probable significant proteinuria. 24-hour collection is slow, and 30 milligram per 24-hour confirmed significant proteinuria. So these are the two tests. One is dipstick, another is protein. Creatinine ratio is also important. If more than 30 milligram per mole, that's probable significant proteinuria. More than 30 or about 30 milligram per 24 hour, that's confirmed significant proteinuria. Principles of management of preeclampsia. There is early recognition of symptomless syndrome. Awareness of serious nature of condition in its severest form, and adherence to agreed guidelines. So principle of management, very important, that early recognition is important. Symptomless, if there are no symptoms like no weight gain, no edema, no tenderness, again, important is that early diagnosis is important, and that early diagnosis in symptomless patient is always checking the blood pressure, and routine antenatal visits are important. In routine, each antenatal visits, usually the obstetricians, they perform urinalysis and blood pressure check. Weight is also recorded if there is excessive weight gain. So all these are important that we should do early recognition. And then awareness of seriousness of the nature. We already discussed about the complications of preeclampsia and how serious it is. Very, very high incidence of fetal and maternal mortality rate associated with preeclampsia. So awareness of the condition is important. Never we should take it light. Well-timed delivery. Once preeclampsia is diagnosed, and if there are routine, it's treated. But again, if it's not under control, and it can lead to eclampsia, and the baby is reached the viable stage, the most important management is the delivery. Once the delivery is done, the condition is recovered on its own. Patient gets better after some time. So well-timed delivery is recommended. Postnatal follow-up and counseling. After the delivery, it takes about 6 weeks to go away, get better. So postnatal follow-up and counseling is also recommended. Investigations performed. We have a full blood count, clotting studies, serum renal profile, and serum liver profiles should be performed. It has effect on the kidneys, it has effect on the blood, it affects the liver. So all these studies should be performed to find out how much damage is done. To monitor fetal complications, we should do ultrasound and antenatal topography that gives the idea about the well-being of the fetus, and if it's affected, then we should plan for the delivery. Management of pregnancy complicated by preeclampsia, again, depending on whether the degree of hypertension is important, how bad is the hypertension. If we admit to hospital, usually it's not required in any type of hypertension, whether it's mild, moderate, or severe. We do not require treatment in mild cases, but in moderate, yes, oral labetalol is the first line of treatment. For severe, again, oral labetalol is the first line of treatment. We should measure the blood pressure regularly, at least 4 times a day is recommended. Test for proteinuria, do not repeat in mild, we do not repeat it, but in this again, do not repeat for quantification, but do not repeat quantification of proteinuria in all three. Then blood test, all types of blood tests are performed. We do kidney function, electrolytes, full blood count, transaminases and bilirubin to find out how much is what's the liver function test, renal function test, complete blood count is the must for patients who have blood pressure during the pregnancy. So all these tests are performed. Treatment of hypertension, we have anti-hypertensive drugs are available. Most safe and most commonly used drug during pregnancy, we have methyl dopa, alpha and beta blocking agent, labetalol, and then calcium channel blocker, we have nifedipine. So methyl dopa, labetalol, and nifedipine are the safe antihypertensive drugs that are used during the pregnancy, induced hypertension. Treatment of eclampsia, mainly magnesium sulfate is injected and given intravenously, and it's very helpful. It reduces the convulsions that can occur if with the eclampsia. So they have seizures. Usually they put in the dark room to avoid any seizure attack, and usually delivery can only improve the condition if the patient is in the viable reaches the period at which the fetus or the baby is viable. Then the treatment is the induction of labor and delivery. Prevent onset of convulsion. So magnesium sulfate, if pre-eclampsia leads to eclampsia, and how we know that it's now in the eclampsia, because the seizures or convulsions are present in women with eclampsia. Doppler ultrasound uterine artery waveform, there is a notch present in waveform pattern which is demonstrate high resistance of the blood flow or the blood vessel. For women already been identified at risk, usually Doppler is performed. That was all about this section. Thank you for watching sqadia.com.